Good morning and welcome to today's webinar, Autism Spectrum Disorder for BH Professionals. Today's training is being offered by the Behavioral Health Quality Department and Behavioral Health Medical Directors and will be led by a psychiatrist, Dr. Danielle Shakuma, and clinical psychologist and board certified behavior analyst, Dr. David Trejo and Dr. Elizabeth Fountain. If you have questions for the presenters, there will be time at the end for questions. Please type your questions in the Q&A box. Dr. Shikuma, I will pass it over to you to get us started, please.
Can everyone hear me and see me?
Yes, we can.
Perfect. Good morning, everyone. Today we'll be presenting on autism spectrum disorder for behavioral health professionals. As you've heard, your presenters today will be myself, Dr. Danielle Chikuma, board certified psychiatrist, Dr. Fountain, and Dr. Trejo, who are both licensed clinical psychologists and BCBADs. Next slide. I will not read the disclosures to you, but here are a few highlights from our legal team. The information provided today is for informational and educational purposes only. Any coding guidance that's received today does not replace official coding guidelines, professional judgment, or expertise. Information today is proprietary and confidential. Any references to third-party sources or organizations are not a representation, warranty, or endorsement of that organization. Discussion of a service or treatment today is not a guarantee that that service or treatment is a covered benefit. One should reference their certificate of coverage for information about benefits, limitations, exclusions, and this information isn't for distribution to unauthorized individuals without express approval. Next slide. Okay, today's discussion will be broken down into 3 sections. Autism spectrum disorder for behavioral health professionals. We may refer to autism spectrum disorder as ASD. Applied behavior analysis, which may be referred to as ABA, and common recommendations and referrals. Next slide. All right, at this time, I will pass this off to my colleague, Dr. Fountain.
Good morning, everyone. Next slide, please. All right, so we thought it would be a good idea to start with just a discussion of what is the diagnosis of autism spectrum disorder. In 2013, the diagnostic criteria were updated. So autism is a multifactorial neurodevelopmental condition. There is no known causal factor. One thing that can be pointed to as causing this diagnosis. Right now, all the research has supported that it's kind of a combination of several different environmental, genetic, and biologic factors, which cause some differences in the brain. And it is categorized as a developmental delay. It is not an intellectual disability, but people with autism could have cognitive or intellectual delays. Many people with autism have average intelligence, and people with autism can be quite brilliant as well. It can be a lifelong condition. Symptoms can improve with treatment and with age. However, like any condition, as people move through the lifespan, the symptoms can affect them in different ways under different conditions. It's typically identified early in childhood. Approximately 1 in 31 children is the current prevalence rate. The CDC released that earlier this year from a study that was based on data collected in 2022. And so by the age of 8, approximately 1 in 31 children were diagnosed on the autism spectrum. And what they found was that boys were 3 times as likely to receive the diagnosis as girls. And autism is one of many other diagnoses that are a developmental delay. And so looking at that in context, approximately 1 in 6 children do carry some developmental disability diagnosis, but for the specific diagnosis of ASD, the prevalence rate is currently 1 in 31 in the US. Next slide. Like I mentioned, the symptoms of autism are typically emerge very early in childhood. Some parents say that they start seeing the symptoms as early as 6 months of age. Typically, the symptoms emerge pretty clearly by age 3. What some families report is that their child develops typically. They hit their milestones until about age 1.5 to 2 years old, and then maybe they stop progressing or they experience a regression. But some common symptoms to watch out for include unusual social communication or interaction skills. So, not having good joint attention, difficulty with making or sustaining eye contact and gazing into the parent's face, difficulty with showing emotion through their facial expressions. As they get older and they start playing with toys, maybe they play with them in odd ways, will only play with specific toys, will only play with them in a certain repetitive way, or maybe that they have some resistance to any changes in their routine, that they want their daily schedule or daily activities to be done a certain way, and they become very agitated or upset if there's any deviation from that. As they get older and begin to show language, they may repeat words or phrases over and over, which is called echolalia. Next slide. And I am going to hand this off to Dr. Trejo if he is available.
Yes, can everyone hear me?
Yes, there you are.
Perfect. Okay. A little trouble with Teams this morning, but I'm in. So early points to behavioral health systems of care. You know, parent suspects something's going on, suspects a delay, has some concerns. Where do they go? How do they gain entry into the system? You know, how do they get access to these different levels of care? Pediatricians are the most common referral source. Maybe at the well baby checkup visit, they might mention these concerns to the pediatrician. There's also early intervention programs whereby there might be a delay in speech or other activities of daily living, and the referral might be made there for additional diagnoses and testing. If the diagnosis or the concerns come later in life, at the ripe old age of 5 or 6, it could be a school-based referral. It could be a teacher that notices the communication delays. Also, in much later in life, other levels of care, sometimes the diagnosis comes in one of these stays or after one of these stays. Not super common than some of the most common ways, like the pediatrician at the earliest stages, but we do see this from time to time. Next slide, please. All right. So once the pediatrician, for example, does a referral to maybe another specialist, the comprehensive diagnostic evaluation occurs. It can happen at age 2, considered to be more reliable at that age. Testing is done at a 4 to 8 hour visit. The results are discussed with the family. You need to check to make sure the family's understanding of kind of why they were there and what the diagnosis means, what testing is going to be done, how long the testing is going to take, depending on whether it's a screener or a more comprehensive assessment. The length of time for that varies greatly. So having them know that is really helpful. Collecting any past history, medical history, is also important to share within the report. The results also are shared with the referring physician to keep that medical history all in one place, and recommendations and diagnoses are given. Okay, next slide, please. So these are some of the more common instruments used So in a diagnostic report, we'll see these and actually often, require these. Most carriers will say, what instrument was used, what specific test was used to test for autism, or how do they meet symptoms? How do they meet criteria? What symptoms were observed? The MCHAT, or Modified Checklist for Toddlers, commonly used at checkups. So you'll see that oftentimes in pediatrician's office if there's a concern. CARS is quickly scored, often done in those offices as well. GARS is a screening tool. So at the end of the GARS, you'll see a higher likelihood or probability of autism diagnosis. It'll recommend additional screening or testing. It's the idea is to screen for, or to kind of triage whether or not additional testing should be done. It's not, kind of stop there, go no further. You have a diagnosis. It's kind of, we have greater concern. You should get additional testing done. Now, the ADOS, often called the gold standard of testing, can take anywhere from an hour to 2 hours. There are 4 different modules, depending on your age and vocal ability. There is an adult module as well. There's nonverbal modules as well, mainly play-based, attention-based, very interactive. Takes quite a while to administer and score it, but this is more definitive. After running this assessment, we know that there is a diagnosis or that there isn't. You want to make sure that CDE is complete. As I mentioned before, having the diagnostic instrument, how they meet the criteria, recommendation for ABA. So is much different, all this, than a letter of medical necessity. I have been seeing patient for 2 years. He has autism, help him. Doesn't meet that criteria of a diagnostic report. Doesn't have the testing instrument, doesn't have, he was seen in my office today and I observed the following. Doesn't have any of that information, doesn't have a referral for ABA. None of that is kind of present in that letter of medical necessity. So a referral, a prescription, a recommendation, all those are different from that report that most carriers are looking for in order to initiate autism services or ABA services. Next slide, please. Okay. So some of the criteria that I mentioned that need to be met in order to have an autism diagnosis is that they must have persistent deficits in 3 areas of social communication and at least 2 of the 4 types of restricted repetitive behaviors. Symptoms must be present in early developmental period and must cause a clinically significant impairment in social, occupational, or other important areas of functioning. And the symptoms are not better explained by an intellectual disability or global developmental delay. There's also a classification of the level of support needed. So level 1 requires some support, 2 being a little bit more substantial, and 3 requires very substantial support. So all of these must be met in order to have the diagnosis of autism. The most recent edition of the DSM is the DSM-5 TR text revision. Came out in 2022, so that would be needed for a quote-unquote current diagnosis of autism. That's what we're looking for. Next slide, please. Common recommendations. So
this one's me, Dr.
Always...
Trejo.
Oh, okay.
No problem. So now that we have a diagnosis, at this point, it's important to make like the appropriate referrals because you really need to have a multidisciplinary treatment approach. Want to make these referrals as timely as possible for the sake of early intervention. The most common and most important referrals are for ABA, ancillary services like speech and occupational therapy, and school-based services. Ideally, we want this referral process to go smoothly and be seamless, but you may need to support the families and caregivers because there may be additional work or barriers ahead. Examples of this may include wait lists for services, geographical access issues, trying to navigate the 504 IEP process to get supports at school. Other common referrals and recommendations you may see are referrals to medical providers for screenings, evaluations, or treatment of comorbid conditions. For screenings, sometimes these may have already been done, but if not, referring for things like hearing screenings. Sometimes they may get sleep studies. Some may be referred for genetic testing. Actually, I think that's kind of routine now. Some years ago, that wasn't as routine. You may be referred for family counseling, as there are a lot of adjustments to be had. There's a lot of unknown that can be anxiety provoking. Support and advocacy groups. You may provide the families with literature or psychoeducational material on autism spectrum disorder. Next slide. Okay. Some of these points have already been mentioned, so I'll just highlight some of the others. Referrals may need to be periodically updated. Clinical best practice is also to do periodic updating of the reevaluation. Most are looking for every 2 to 3 years. The reason you're reevaluating is not necessarily because you think they're no longer autistic. That may be the case with treatment, but symptoms change, needs change, some of the deficits change. So then, the treatment needs may change. So we need to stay abreast of what's going on so that you're giving appropriate treatment interventions. And some things change, whether it's with the treatment interventions or just with normal aging and maturing. When referring for med management, you may need to consider a psychiatrist or a neurologist that has experience working with individuals with autism. Also, we've mentioned the wait list before, but I'll say this: if there are wait lists, still encourage families to sign up. They can always decline should their needs change or should they no longer need those services. Additionally, the families may benefit from case management or coordination of services. This can be explored either through their carrier, their insurance plan, or their county authority for intellectual and developmental disabilities. Next slide. Okay, this is just a list of common conditions that may be seen in individuals with autism. This also speaks to the importance of the individualized multidisciplinary treatment approach to provide more effective treatment, to improve outcomes, to improve functionality. This is where speech therapy, occupational therapy, psychiatry, neurology, feeding therapy, primary care providers, GI specialists, this is where they all come in. I also encourage families to sign release of information to make it easier for collaboration between the treating providers and the primary referral source as well. With regards to, I'll say ADHD, with ADHD, approximately 40% of children diagnosed with autism spectrum disorder also have a comorbid ADHD. Intestinal issues, food aversions, restricted diet. These kids are like 5 times more likely than their peers to have some sort of eating issue. I won't say necessarily disorder, but an eating issue, whether it's related to texture or they're restrictive about what they'll eat or they won't eat. Gastrointestinal issues commonly are constipation, maybe diarrhea, abdominal pain. So these are definitely ones to be on the lookout for and to ask about. Next slide. Okay, so this is just being considerate of the individual that is in front of you, not just here are the routine things that we may make a referral for. The person has anxiety, I want to start them on meds, I want to send them to therapy. Well, if they have significant comorbid issues with language processing, language expression, then that's probably not a good fit. Or if they don't have the skills to deal in group therapies. Okay, someone has eating disorder, I'm going to refer them to this group treatment. They may not have the skills to do that. So be mindful of the client or the patient that is in front of you when you're making your recommendations. Next slide. Okay. So this one we could actually talk about all day, but I will try to keep it brief. This is looking at medications used in the treatment of ASD-associated symptoms. The reason it says ASD-associated symptoms versus ASD is because there's no pharmacological treatment for like the core symptoms of ASD. You're typically targeting symptoms that may be associated with another comorbidity or target symptoms that impact functioning that you can try to do something with meds. So psychopharmacology, this is just one component of the treatment plan. Remember, it should definitely be multidisciplinary. So if the prescriber is the only one on the team needs more team members. In general, approximately 2/3 of children with autism, or at least 2/3, are on at least one psychotropic medication. And then about 1/3 are on 2 different classes of medications. The most common ones that you may see a child with autism on are stimulants, antipsychotics, and antidepressants. As we previously mentioned, with the stimulants, of course, that's going to be common when 40% of children also have comorbid ADHD. Now, the caveat here is sometimes with starting a neurotypical child on stimulants, yes, you may see side effects, but the chances of a response tend to be higher. They tend to be less sensitive overall to some of the side effects, whereas kids with autism, they may experience lower response rates, higher sensitivity to side effects, and this can contribute to higher dropout rates as well. So some of the most common side effects you have to be on the lookout for: irritability, aggression, emotional dysregulation, sleep disturbance, and decreased appetite. As I stated, you can see these in anybody on these medications, but you have to be particularly sensitive with the kids with autism. And it kind of stinks because some of the reasons you're using the medication to treat things like emotional dysregulation that may come with ADHD, some of the irritability that you also may see in ADHD, but then the kid turns around and has side effects from the medication that worsen those symptoms that they were having. So just be sure to do informed consent and, let caregivers and families know that this can happen. Don't give up. It's on to the next. We'll come back to the table and try something different if we need to. Next, there are antipsychotics. Specifically, I have mentioned on the slide Risperdal and Abilify because these are the only FDA-approved ones for aggression, irritability, and self-injurious behavior in autism. Again, you have to be mindful of side effects. Potential side effects include weight gain, increased appetite, metabolic changes like increased blood sugar or increased cholesterol, fatigue, drooling. With Risperdal, you may see breast enlargement or galactorrhea, and in the long term, movement abnormalities like tardive dyskinesia. And with that weight gain, if you see weight gain, some prescribers may try to switch to a different agent, or they may attempt to add metformin. Let's say the medication seems to be working well for the child and it's more important to keep that child stable, then maybe they'll try metformin. If you try metformin, again, you have to be mindful of potential side effects and try to encourage them to keep the child on the medication for at least 3 months. So some of those potential side effects include irritability and aggression, GI upset, changes in liver function tests. Antidepressants. Okay, so you may be using those for, comorbid mood and anxiety disorders, or sometimes they're trying to target repetitive thoughts, repetitive behaviors that may be seen in autism that are not necessarily OCD. So the results on that, they don't tend to be as good as maybe you might see in actual OCD. Again, potential side effects: agitation, aggression, hyperactivity and sleep disturbance. Over here on the right, where it talks about memantine and cholinesterase inhibitors, the jury still seems to be out on that. They say there may be some promising research with regards to helping with social behavior deficits and actually just in general the core symptoms, but we don't have support for that, but it may be on the horizon. Other considerations that aren't necessarily listed on this slide when prescribing, there are things to think about. You know, can this kid swallow pills? If they can't swallow pills, then the med that you're prescribing, can the med be crushed? Is it a capsule that can be opened? Does the medication come in another form, liquid or transdermal patch? Do you need medication levels on the medication? So, you know, there are other things that may make it a little more complex that you need to be mindful of. As far as side effects, yes, of course, we know that there's a possibility of having them, but are there times that you can use the side effects to the patient's advantage? You know, if there's one that may help them, but it may cause drowsiness, can we prescribe at night? Also be sure to discuss the possibility of paradoxical reactions on medications because that can happen too. And just be mindful of polypharmacy. It can easily happen, especially with this population, as you're trying to target the different symptoms that may be impairing functioning and you're trying to help, and more medications get added, and then we're not really sure what's doing what. So make sure there's clear documentation about responses and, you know, why certain medications are being added, and continue to assess whether a medication is still needed, and, you know, if not, take it off. Other considerations, if the child is of school age, they may need to take medication at school. So two things with that. You need to check with the school nurse or with the district, because in some districts, they have very specific rules about whether they will administer medications or not. If they do it, then you'll sign a form giving them permission to do it, and they need the provider or the prescriber to be very specific in the instructions, because the school nurse is only going to administer it exactly as it's written. So sometimes it may be written for a parent twice a day. Well, you know, for the school, it needs to say twice a day at this time, or, you know, it needs to be very specific, or otherwise they won't do it. And they may also need to ask the pharmacy for 2 bottles so that the school can have a bottle that specifically has the prescription on it, and then they can keep one at home so that the parent has a record of that as well. I'd also like to add, don't overlook asking about complementary and alternative medicine. Families, they may be using them and not say anything for many reasons. Sometimes it's because they don't realize that it may be important to their child's care, or, you know, what they're using could interact with the medication that you're prescribing, or they just may be reluctant to say out of like fear of judgment. So be sure to talk to the patients. Of course, you're going to give them the evidence-based information of what's supported, what's not. Sometimes it may be more important to focus on whether the treatment that they're doing is harmful. That may be a better focus, and just continuing to encourage them to be vocal about what's going on and to continue to come to their prescriber to discuss it, or to look more into whatever research that they're saying that they did. Let's see. Next slide. Oh, okay. So here I just wanted to add that another level of complexity to consider is sometimes children with ASD they may not be able to tolerate some things that their peers may better tolerate, routine dentist appointments, or if they need to get dental work done, if they need blood draws, if they need to get their vaccinations done, if they're on medications for which there need to be lab draws and it needs to be monitored. Or sometimes just routine tests and screenings, or if there have been injuries and they may need imaging. These things may complicate the treatment. Be mindful of that. Sometimes these kids may need sedation for certain procedures, or if there's an injury, trying to find out if there's a specific location or hospital that actually is equipped to handle these kids, whether they have imaging on site or that they're willing to provide some sort of sedation to allow for the treatment to occur. And next slide. All right, I'm going to pass this off to my colleague.
Next slide, please. So a commonly recommended treatment for autism spectrum disorder is applied behavior analysis. There are very few scientifically supported treatments for the symptoms of autism. Many are still considered experimental or investigational. Some treatments have been found to be ineffective. Other treatments come with a host of side effects that can be very harmful to individuals. While some do show some promise, unfortunately, with replication, consistent positive effects have not been able to be supported. So right now, there are very few scientifically supported treatments to address deficits that are associated with the diagnosis of autism. ABA is one of two. The other is early intensive behavioral intervention, which includes components of ABA along with speech, OT, physical therapy, play-based therapies. But autism treatment as a standalone, ABA is scientifically supported to be effective. It's very important. There's a lot of discourse out in the public sphere right now. Some people support ABA, some people are very opposed to ABA. Like any treatment, it's very important to do your research, find a qualified licensed provider, look at the reviews, make sure that the person is following appropriate ethical and professional standards. And then, ABA, it's not designed to therapy the autism out of someone. It's really supposed to identify specific deficits or barriers that are preventing the person from accessing the least restrictive setting or achieving full independence, and meeting those needs in a supportive and appropriate therapeutic way. So what ABA does, how it works, is it is a very intensive therapy, but it uses procedures based on the science of learning and behavior to teach skills and address problem behaviors that are interfering with the person's overall functioning. It is a fairly new science, looking at the history of medicine in total. It was officially recognized as established in the 1960s. There was a lot of research studies published over the course of the next few decades that really established it as an effective treatment. And what it does is it works to identify the relationship between an individual's behavior and their environment to increase skills and behaviors that that person needs in a functional way, to generalize them across people, across settings and situations. And if there's anything that's impairing the person, if there's a problem behavior that's causing difficulty for them, preventing them from fully accessing and participating in different areas of their life, they want to reduce those and replace them with more functionally appropriate skills. Next slide. The ABA model of care is a little bit different from traditional outpatient therapies where you might think of, one therapist meeting with one patient for, a 60-minute session, right? What ABA employs is a tiered service delivery model where you have a board certified behavior analyst at either the master's or the doctoral level who's the one who oversees and supervises the care. That would be the person who does the assessment of that individual's needs, who meets with caregivers, parents, does testing, would write a treatment plan, develop goals, and really establish what the services are going to look like for that individual. But they're not the one who delivers the day-to-day frontline therapy. Instead, that's delivered by a technician level individual. There is a national certification available for a registered behavior technician, but it does not require a professional degree. But it does require specialized training, examination, and ongoing continuing education for that technician certification. It might be just one technician or it might be a team of technicians. And so they're the ones that are delivering that day-to-day therapy directly to the individual. And that BCBA then supervises those technicians, provides some face-to-face supervision services, feedback, updating the treatment plan, and overseeing a certain percentage of that day-to-day care. Next page. So like I mentioned, ABA can be very intensive. And so people are often surprised, especially when you're talking about very young children, that they may be receiving a comprehensive program of up to 30 to 40 hours a week of therapy. And that sounds like a huge amount. But for individuals who have pretty significant deficits across multiple skill areas, so communication skills, play skills, social referencing, compliance with direction, receptive language, expressive language, all of these different areas, it's really necessary to have the time to effectively target all of these different skills. And so what science has shown to be effective at teaching these skills is a 30 to 40 hour a week program for a duration of typically about 2 to 3 years of this intensive treatment. And that helps to close the gap between the individual's developmental age and their chronological age, and essentially get them caught up to their typically developing peers so that they're able to function more independently without needing as much support. This approach is typically found to be most effective the earlier it started. So as soon as diagnosis happens, that referral process needs to kick in. And typically children will start this before they turn 5. So usually around between age 3 to 4. And they'll get that for about 2 to 3 years. It's most effective if it's started and completed prior to age 8. However, there's also a less intensive approach to ABA, which is considered a focused program. For individuals that don't have as many deficits, maybe that level 1 level of support needed for the autism diagnosis, maybe it's just social skills, or maybe they're just having difficulty with one particular area of higher level communication. They wouldn't need 30 to 40 hours a week because there's not as much symptoms or deficits to treat. And so for those individuals, they might just need a focus program, about 10 to 20 hours a week. Focus programming is also typically used as a step down in care after receiving those comprehensive services. It addresses that narrower scope of deficits or higher priority needs. It's also common in older individuals. So maybe someone received ABA when they were younger and then were successful and stopped treatment. But as they move through the lifespan, their symptoms impact them in different ways as new challenges emerge as they get older. And so they might come back into treatment for a focused program for a short period of time just to address those acute needs. Where treatment happens, it's typically in a home, the family's home, or in an outpatient clinic. And that's referred to as a conventional location. And the reason for this is in order for therapy to be effective, that therapist needs to really systematically be able to run the goals in the treatment plan, target those skills, control that environment, control all those variables so that they can effectively implement the treatment goals and deliver the reinforcement to teach the individual the skills that they need. However, ABA could occur in other locations, which is kind of grouped into non-conventional treatment location. And these might include community settings that the family is accessing. In school, there are many special education programs that utilize ABA-based curriculums, recreational programs, job skills training programs might utilize ABA techniques, day programs, vocational training type programs, day habs, camps. There are many camps that are out there that utilize ABA interventions. But what's really important to consider when you're meeting with families and referring them for these services, that the treatment really needs to be therapy. And it's very difficult in these other environments and other programs where there's competing demands for an ABA therapist to be able to effectively run through all of those treatment goals in a systematic and structured way. And so if what ends up happening is the therapist is just following the individual around and kind of prompting them and helping them to access this other program or activity, well, then that's no longer truly therapy. And it's more of like an aid support or a respite care. So when we're delineating the difference between ABA and more wraparound style supports, what's important is that the therapist is controlling the session and has kind of previously determined what they're going to work on that day, that they have full control of the environmental variables, and that they're just using that location to have access to those variables so that they can run those skills goals from the individual's treatment plan. Next slide. So here are some examples of what those goals might look like. So for example, if a child is having difficulty using functional communication to ask for help, and instead they're just falling to the ground, having a tantrum, crying, screaming, then what the therapist would do is contrive situations where they repeatedly introduce situations where the child needs to ask for help. So maybe they hand them a snack, but it's in a container that the child can't open. So they prompt the child to use their functional communication to ask for help, and then the child's rewarded with access to that snack. Or maybe they're playing a game and there's a piece that they need and the therapist has it, and they need the adult to assist them to set that game up. So just prompting them repeatedly to use that skill of the functional communication to ask for help. And they'll have it structured in their therapy session that they're going to work on that 10 times throughout the day. They will give the child breaks, of course, and they'll reward the child when they get it right, and they'll provide appropriate intervention and redirection if they get it wrong. But it's pre-planned that they're going to target this skill X amount of times throughout that therapy day. Another example, so a child who is working on receptive language to follow directions. It's a two-step direction. So the therapist is going to have already set up that environment with items, and they'll tell the child, okay, go to this location and bring me the fill in the blank. And so they'll work on that multiple times, and they'll be collecting data on how successful the child was with correctly following that direction. And once they are able to do that, appropriately, accurately across 3 consecutive sessions, then that skill is considered mastered and they can move on to the next skill. Another example, a child who's working on social skills, turn taking, sharing with peers. So the therapist will be with the child and will facilitate their interaction with peers. It could be siblings, it could be other children who are also receiving treatment. And they'll set up a structured play session where they're prompting that child to engage appropriately, and they're prompting that child to pick up on the social cues, and then they're reinforcing that behavior, and then the child is able to successfully access the peers and the play schemas that they're trying to teach. Another example for a child who's working on functional communication skills, they'll set up maybe through assistive communication like a picture exchange or an electronic alternative communication device. You'll often see children using tablets to communicate with specific software that's set up for that. But they'll have a whole menu of items that the child might want to engage with or ask for. And so they'll teach the child how to use that functional communication, either vocally or with assistive communication techniques, to be able to get their wants and needs met. And they'll be collecting data on how the child is able to do this with how much prompting until they're able to do that independently. So these are just all examples of specific goals that might appear in a child with ASD's treatment plan for ABA. Next slide, please. And Dr. Trejo, I'll hand this off to you.
Okay, so now I'm going to talk about the research and efficacy of ABA. So the landmark study was in 1987, so not that long ago, I guess, for maybe some of the Gen Xers in here, that this study was done, finding the efficacy for applied behavior analysis in the treatment of autism. Lobos was initially looking for participants with schizophrenia, childhood schizophrenia, but had a hard time finding participants. Instead, kept getting referrals for young children with autism, and then proceeded to do this study with them instead and found some pretty good results. The research has been supported in later studies as well, and there's some lit reviews below regarding some of the efficacy of this work. Next slide, please. Okay. Now, this is Lobos's 1987 study. There were 38 participants, so 19 in the experimental group and 19 in the control group, and there was a second control group that received no intervention at all. Now, the experimental group received 40 hours of one-to-one treatment and intervention. At this young age, they were between the ages of 2 and 4 years of age. The control group received 10 hours of eclectic approach, so your special education or other approaches of the day, but nothing like ABA-like, so to speak. And they received this treatment for 2 years. So here's an important note that it was for 2 years. Next slide, please. Now, results for those 19. 9 achieved average IQ and no longer met criteria for the diagnosis after 2 years of intervention. So, this was unheard of at the time. So another about half, 8 made some gain but did not remediate all the symptoms and retain the autism diagnosis. And 2, despite 40 hours a week for 2 years, received no benefit from the treatment whatsoever. Test scores were the same, adaptive and intelligence scores were the same at the beginning and at the end of treatment. So that was good news. About 50% received what's called now optimal outcome. Next slide, please. So early on, there were terms such as recovered or cured or indistinguishable from peers, no longer met diagnostic criteria, have been replaced in outcome literature and meta-analysis literature with optimal outcome. There were some criticisms of the study early on. They said that Lobos cherry-picked his participants to be in the experimental group. You're selecting the ones with better eye contact, better IQ, slightly higher IQ scores. Maybe 2 years isn't enough treatment, and the like. So there were replication studies done later on. So a second 2-year study, a 3-year study, and a 4-year study. So if 2 years wasn't enough, let's see 3 years, let's try 4 years. But that 50% we saw in the 2-year study repeated over and over. So 2 years, 50% reached that optimal outcome. 3 years reached that optimal outcome of 50%. 4 years still reached that optimal outcome of 50%, hit that no longer met the diagnosis sort of outcome. So beyond 2 years of intervention, the efficacy is greatly reduced. At that point, oftentimes, as Dr. Fountain referenced, they're usually titrated, faded out of treatment, and we begin to focus on activities of daily living, communication, problem behavior, but at a lower rate. We start looking for next level of care. What is ABA being prepared, used to prepare them for? So we're no longer in a comprehensive at 40 hours a week. We're now beginning to fade our way out maybe to 25, 20, 15, 10, and beginning to fade out of treatment at that point after about 2 years. There are other outcome information kind of in the field, diagnostic instruments such as the PDD, behavior inventory. TRICARE, the largest insurance carrier in the world, did a 10-year autism demonstration project. They found after that 10 years, an efficacy of much, much less than 50%. It's still hotly debated in the field about the use of this instrument and for outcome data. But that is a published study that's out there and has taken congressional testimony and seen providers to gather their own data. They're now submitting data to an international consortium of medicine, the ICHOM study, with their own data to kind of gather efficacy data in real world settings across different carriers in the United States and in Europe as well. They selected standardized assessments in the US as the Vineland and SRS2 for the ICHOM studies. And providers are able to submit that data to that study. And then within a few years' time, we'll have information regarding kind of some of those real world outcomes, how close we are to the academic outcomes we saw, that like 50%, for example. Again, after some amount of treatment, some of the outcomes we look at as problem behavior. Do you still have dangerous to self or others problem behavior? Is it near zero? Can you access a lower level of care, or does this interfere? Do you need a higher level of care because of that problem behavior? The level and intensity and frequency of problem behavior may affect a patient's access to different levels of care and settings. So, for example, group home settings, oftentimes won't take a patient that engages in aggression. Then lack of progress is sometimes we see. As we noted in the research, there were a certain percentage of individuals that saw no benefit to ABA at all, even after years and years of treatment, full-time hours. We see this as well, and sometimes that is a reason, and it's an ethical requirement of ABA providers to discontinue treatment when a lack of progress is noted across multiple authorization periods. It can be hard. I mean, you figure that someone that is spending hours and hours and hours of time in a family's home or with a young child, despite seeing the lack of progress after months and years of treatment, they may hold out hope for continued progress or latent progress, but oftentimes it's an unfortunate thing that we see in the real world. Next slide, please. Okay. That one.
Yep, I'll take it over, Dr. T. So talking about common recommendations and referrals. So outside of ABA, there are other services and supports that are available. And so we just wanted to take some time to review what some of these are, because it's important as you're working with families to make sure that they're aware of them, what their rights are, or what's available and accessible to them. Next slide, please. So some community supports, the most common one for children, of course, is school-based services. So under FAPE and IDEA, so the Free and Appropriate Public Education and Individuals with Disabilities in Education Act, so federal law, any individual who has physical, medical, or cognitive conditions that affect their learning are entitled to services and supports to allow them to access and participate in their education in the least restrictive available setting. And one of these is through a 504 plan, which provides some protections for individuals in different programs that receive federal funding, for example, public schools. And what it does is it allows for documentation of specific accommodations and supports that individual might need for both in the school day as well as extracurricular activities that are provided by the school. The 504 plan is different from an IEP. So it would be for students who do not require special education services. It's very important when you're working with families to educate them about the need to sign for release of information, because like on the medical side, there's HIPAA, schools have something called FERPA. And so in order to communicate with the child's teachers or school personnel, or even to access these documents, they would need to sign a release. And also the schools may have some additional documentation that they require parents to fill out in order to be able to develop this type of supportive plan. Next slide. Also, if a child is evaluated by the school and found to have a special education classification of autism, they would be able to receive an IEP. So this would allow them to receive special education services, and it outlines any type of specialized instruction that that child needs or any supports that that child needs for the child to access and make progress in their educational curriculum. So that IEP document is going to identify specific measurable learning goals for that child, any accommodation the child needs while they're in school, a specific way to meaningfully track their progress and make sure that the IEP is having the intended effect of meeting that child's needs, and any related services that the IEP would need to fund. So, for example, speech, OT, ABA. These can be funded through the IEP if the school determines that they are necessary for the child to access and participate in schools. And so, families may be unaware. As we all know, many school districts are underfunded, understaffed, and have difficulty with being able to meet all of their learners' needs. But the family does often need to advocate for their child and be able to hold the schools accountable for following the plan that's documented in the IEP. And if that plan is not working, to be able to call another meeting to potentially add additional services or supports to help their child make progress, or to be able to fully access and participate in school in the manner in which they are entitled to by law. Next slide. Some other common recommendations and referrals that you can make as you work with families would be to refer them to early childhood intervention services, which provides support for the family. This is typically for younger children, including like a transition to preschool or when children age out of early childhood intervention. Also, while services can vary state by state, depending where you're located, you want to make sure that the family is signed up for any Medicaid waiver programs that may be available where they live. The wait lists for these can often be incredibly long. And what we typically recommend is just sign up for it, because if it's a 10-year long or a 15-year long wait list, you have no idea what your needs are going to be 10 or 15 years from now. Sign up, and when it becomes your turn, you can always turn it down if you don't need it, and it will go to the next person. But if you don't sign up and it's a 10 or 15-year wait list, then you could be sitting on that wait list for a very long time waiting for services that you actually need. And just, as soon as that diagnosis happens, just educating the family about what's available so that they can sign up, especially in more rural areas where programs are further away to access, or there just aren't as many qualified professionals. It's very important to let the family know to get signed up for whatever they're eligible for. Next slide. All right. Dr. Trejo, I believe this was you.
Okay. So patient-centered care, autism throughout the lifespan. So there's different training protocols, like I mentioned. Much of the research. Oh, is my camera not? There we go. Much of the research, like a large portion, almost all, is done with children that young age, that under 8 crowd, 9 crowd. I mean, that 2 to 4 is the majority of the efficacy research. But of course, autism persists across the lifespan, and there's different needs at different ages as well. So your early intervention stuff might include feeding and toileting, for example. But later we'll transition to stuff like other needs as well, as like educational supports, seeking out an IOP, an individual education plan, or a 504 plan, or an ARD. ARD, depending on the state you live in, it may have slightly different names, but it's essentially the same process. It's those supports that are provided by the public school and that are guaranteed in every state as a federal law. Do they need behavioral supports as well that are provided by the district? Social skills programs, not necessarily just ABA, but they could be speech. It could be a group speech social skills program where they work on social and speech pragmatics and taking turns and noticing body language, and all that done in speech as well. So outside of ABA, there is a wealth of efficacy within those as well. Life skills, as we begin to move on, they need help with things like as they get older, maybe like bus schedules or shopping or finding the expiration date on the milk, finding the one that doesn't expire yesterday and buying that one instead, using coupons or whatever have you. But as they get older, into adolescence and adulthood, those are some of the skills that kind of come into play, and that may not be covered by medical insurance, as they'd be covered in other areas, or might be part of the parent ed curriculum as well, to kind of teach the child through that means instead of directly through therapy provided by a technician. Adolescents, sexuality, body image, safe internet usage is a small area within ABA. Many of the providers, your technicians want to work with the 2 and 4 year olds, but there are teens that need help in this issue and can become victims, if not kind of educated early on about some of these concerns. There's a dating show on Netflix that addresses some of this and kind of has some of those conversations between parent and child, and from the therapist that comes out on the show as well, kind of having some of these conversations and kind of demystifying some of that as well. Adult services are harder. So as the patient ages, supports get fewer and fewer, and it gets harder and harder to find them. Most states do have vocational support programs. Texas has, Texas Workforce Commission has a program that provides support in the workplace. So not covered by medical insurance, but the Texas Workforce Commission has this program where oftentimes they were hire out ABA providers, VCPAs, to kind of work with and do kind of a vocational training and see what supports can be done there, job finding and searching, and kind of support on the job. Transitional programs where transitioning out of high school, you've reached age 21 or 22, depending on your state, and now you need to transition into a community setting or a different program. So that could include support at a university, for example. Well, now maybe less such so, but day programs as well. Care throughout the day, activities, outings at these day programs as well. So like an adult day program often includes transportation. And again, here's where aggression. So if you're an adult that engages in aggression, that's going to limit the amount of places you can go. So for example, some day programs will not tolerate any aggression. Some will have appropriate staffing that can work with some, but it really kind of, is dependent on the individual and the program and the search that should begin as early as possible. There was discussion earlier about the waiver programs for most states. The wait lists are up of 10 years. So even when you have that early diagnosis at age 2 or 3, you still want to get on that wait list, because it may take 10 years or longer. In some states, I've heard 12 years. But in order to have access to some of those programs later in life, you might not need it. But if you do, it's good to have been on that wait list for that time. Or if they move, we had a patient recently move from another state, and they had to kind of start over on that list. So it limited their options. They're considering moving back as a result. Next slide, please. Okay, and here are some additional resources that we've kind of included in the slides. I think several people have asked if we're going to send the slides, and yes, they'll be available, and we'll have some of these slides as well, or have these resources on the slides that you receive. Next slide. Okay, got to the question part. I tried to hit as many of the questions I can in the chat, but.
You did, Dr. Shakuma, Dr. Trejo, Dr. Fountain. Thank you so much for all your time today. I know we are not able to get to all the questions today at the end here. Dr. Trejo, you answered many of them throughout the presentation, so thank you so much. a wealth of information. Just for everyone again that is here, please know that you will receive an email link to complete the evaluation and attestation for today's webinar, so that you can receive your CME or CEU credit. You'll receive that link 24 hours after this webinar ends today, so likely tomorrow. You can access the recording there, and if you would like a copy of the slide deck, you can also download a copy at that same site that you receive your CME, CEU. It's the site that you registered for today's training at. Um, Again, thank you all for attending, and thank you for today's wonderful presentation.